Good afternoon. I'd like to welcome you to today's Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities in the UVA Medical School. We're delighted to see you here today for a program entitled Doctors as Makers. Understanding and responding to patients' complex health needs and challenges has always required doctors, indeed all healers, to think creatively. Knowledge and information are not enough. The practice of medicine, like other facets of human life, is also fraught with uncertainty and ambiguity, however much we may credit biomedical science with rendering objectively knowable the body, its processes, and its progress through the world. In an era of diagnostic sophistication and precision medical therapies, perhaps now more than ever, we must prepare future physicians to think differently and to be mindful of how they think. Indeed, future physicians must also possess the skills of a creative artist. Because for many doctors on the clinical front lines, medicine is actually a science-using creative act, and an enterprise that deeply engages one with the uncertainty, ambiguity, and even mystery of the world we live in. What does this signal for how we teach and train doctors? This Medical Center Hour is the School of Medicine's annual Moore Lecture, endowed by the family of UVA medical alumnus Dr. Ellis C. Moore, and offered each year by a physician or other health professional whose writing has made a mark in the world. So we're pleased to welcome today as this year's Moore Lecturer, emergency medicine physician, medical educator, and fiction writer Jay Baruch from Brown University, where he is an associate professor of emergency medicine and director of the Medical Humanities Bioethics Concentration at the Warren Alpert Medical School of Brown University. Dr. Baruch is at the forefront of medical education initiatives that enlist the arts and the humanities in schooling medical students' core clinical competencies, including their creative and critical thinking, their moral imagination, and their ability to tolerate ambiguity and uncertainty. At Brown and elsewhere, including UVA, such new education strategies move beyond the lecture hall and the laboratory and into the writer's workshop, the design studio, and the art museum. As he's done in some of his recent scholarly writings, Dr. Baruch will here make the case that these necessary transformations in medicine and medical education will demand our developing new interdisciplinary skills, methods, materials, and sites for teaching medicine. And they are now requiring new interdisciplinary and interprofessional collaborations with and contributions from artists, writers, designers, and humanities scholars. I'll quickly mention Dr. Baruch disclosed no financial conflicts of interest for this program. He is also, though, as a writer, the author of 2 wonderful volumes of short stories, both of which are available in paperback in UVA bookstore, is outside with copies of 14 stories and What's Left Out. And following the program, Dr. Baruch will be happy to talk with you and to sign copies of the books. I'd also like to thank the UVA Medical Alumni Association, which is our partner on the Moore Lecture each year. Thanks so much, and please join me in welcoming Jay Baruch.
Thank you all for coming. It's really an honor to be here and to visit with you all in Charlottesville. I want to thank the Moore family. It's a great privilege for me to come down as part of this lectureship. I want to thank Marcia and Danny Becker and the faculty and the students who I've had a chance to meet with. I think it's been more of a treat for me. I hope I'm able to give back at least a little bit. So I'd like to, over the next probably half hour, share some ideas with you, and hopefully get your responses and your thoughts on some of the points I'm making. So. When I finished medical school and I completed my emergency medicine residency, I felt pretty good about myself, my professional self, so to speak. I owned or rented at least a solid bank of medical knowledge. I possessed a necessary set of procedural skills, and I, at that time at least, was filled with the youth and the energy to take on this new life as an emergency physician. There was only one problem. Patients didn't always cooperate. They didn't always follow the script. They would come with symptoms, but they weren't exactly puzzle pieces that fit neatly into a diagnosis. And it so happens that medical issues were straightforward. The table upon which this puzzle sat was unstable, destabilized by socioeconomic issues, substance abuse, mental health concerns, homelessness, threadbare social fabrics, and so on. My patients were embedded in a web of needs that made me sometimes feel overwhelming. They were ungraspable, and sometimes it actually felt intimidating as well. The answer wasn't always A, B, C, or D. And this was a source of great frustration, the impasse to find the answer and unable to do so. And it resulted in anxiety, a little bit of self-doubt, and a whiff of disillusionment. And when I was tired, hungry, having a bad day, this frustration sometimes bled into my behavior with patients, as if somehow I was blaming them for not being a puzzle with a missing piece. And when faced with layers of problems or unruly stories, the biggest challenge I had to learn was learning how to ask the right questions. What soon became clear to me that was not all these patients actually expected an answer from me, but they insisted upon and deserved a meaningful response. And to do that, I had to first learn how to swim in the waters of uncertainty and ambiguity. So for me, in my work in the emergency department, understanding my patients and approaching them feels a lot like stepping before this Twombly. It's not necessarily a puzzle. When students look at this painting, there's no soft landing spots. There's no place for them to start. They don't know where to start. And so what they do is, invariably, they look for something recognizable. You know, are those, I don't know how well it's projected,
Can you
but...
put the lights down a little bit? Just, John can turn them down. Yeah,
Okay.
there we go.
Are those hearts in the center of the painting? Perhaps those are butterflies sort of flying off the side. But either way, they're trying to find something recognizable. And this painting, this Twombly hangs in the Rhode Island School of Design Museum, the RISD Museum. And what we have done, one exercise we've done in concert with the RISD Museum educators, which are so extraordinary, is we work with students sort of in small, different artistic tasks. And one of the things we do is we have the students select one area of the painting and sketch the positive space, the areas that they believe have marks or information. Then we have them sketch the negative space, the spaces around the marks, supposedly without information. And in this manner, students begin to see how negative space is always relational, it's always in reference to something, and how marks in their absence can communicate ideas. We asked students to then make an abstract drawing of a conversation they had, capturing what they considered was the positive space in the dialogue and the negative space. And through questions and crude art making, we make connections back to what is unsaid or unsayable in medicine. Because where we set our eyes and what we value as relevant information are decisions that we're making before we even think that we're making decisions. We wanted students to become aware of how they think, and how can we challenge students to think about how they think when they still lack the requisite medical knowledge. The works in the RISD Museum represent complex bodies of information. Like patients, they can elicit strong emotions and forge powerful connections, as well as appear inscrutable, overwhelming, and yes, at times unappealing. Through sessions such as this one, we give students the opportunity to play with uncertainty and ambiguity, to become aware of how they deal with nonlinear, non-sequential information, what details they choose to hold on to and why, and how it makes them feel. And then, how do they learn how to communicate from within this experience? Because the stakes are high. When this Twombly comes into the ER, I can't ignore it. I can't walk past it. There's only one path, and it leads directly to the patient's room. So my entry point into this work, this interest is creativity in medicine, is personal. Early on in my career, I was very frustrated, and though I probably didn't admit it back then or didn't realize it back then, I was probably a little bit burnt out over the increasing complexity of the patients that I was seeing, the layers of their problems, and most importantly, in the fact that I was letting them down in some fundamental way. And over time, I soon realized that my response to their complexity was to draw on my creative writing skills at the bedside. I felt less compelled to fit patients and their stories into a box and to begin to think of them as complex characters and unique narratives. And one helpful tool that I ended up leaning onto again and again, and I use it to this day, is when you're writing and you're stuck. Oftentimes people will think about plot, think about moving forward, and oftentimes when you're stuck, the first movement is to try to understand character and to move backwards and to find out how you got into the situation in the first place. And when patients come to me with really complex stories, sometimes my first question to them is, okay, walk me through your day, tell me what happened, what made you, at what point, what were you doing that made you take the step to come into our emergency department and wait. Because that's a movement, that's a narrative movement. It also became apparent to me early in my career that to become a better doctor, I had to become more creative in my thinking. And actually then, at that point, I felt I was beginning to develop my voice as a physician. So what do I mean by creativity? Alan Blakely, the humanities scholar, describes creativity as a weasel word as it pertains to medical education. That is, it's sort of slippery to define, and it's inflected with many different personal meanings. But practically, I'll think about creativity in these terms. It encourages new connections and relationships between disparate ideas. It demands curiosity and the ability to ask different types of questions, which also means foregoing that impulse to immediately go into problem-solving mode and try to understand the situation more first. It demands curiosity and the ability to ask different types of questions. It emphasizes process on the road to products. We're very outcomes-centered in medicine, and we should be, but we also should focus a lot more on process and be able to document and make that process tangible. We need to frame constraints as opportunities, and God knows we have many limitations and constraints. We're also facing challenges in medicine, but rather than sort of casting blame and complaining about them, perhaps we should be thinking more creatively about them. We need to develop comfort with stepping out of our comfort zones, and last but not least, generating a space that makes failure allowable, and that failure is actually part of the creative process. So, in this paper that I wrote, Doctors as Bakers, the premise was to expand the traditional role of a doctor as a science-using, evidence-based practitioner to include that of a doctor, a creative, and an artist. And I don't think this idea is terribly new. This is not a profound statement. We've always, if you think about it, we've always been makers. Doctors have always been makers. We make diagnoses, we make prognoses, we develop treatment plans, and we build trust. There's a lot of active verbs in there, what we're doing. It's very constructivist. And if you think about it, we use materials to do this. And those materials are knowledge and story, and it's flesh, and it's blood tests, and it's urine, and it's diagnostic imaging, and we also have to include our emotions and our judgment into that. And all these things are, if you think about it, are fragments, and these are fragments that we're using to construct understanding and to construct decisions. The challenge is that we often put a weight on knowledge. I include this slide because this actually was an article in 1978 in New England Journal of Medicine where they actually try to weigh knowledge. And they weigh the Index Medicus from 1879 to 1974. And big shocker, there's more information in the Index Medicus in 1974. But the reason why I include this is the idea of the weight of knowledge. So there's, I think about it in metaphorical terms. And the fact that, weight can also be heft and immensity, but weight can also be a burden. And this trend about the expansion, the exponential growth of knowledge is nothing that's new to us. And not only is there more knowledge now in 1970s than there were in 1879, but between the 2000, 2010, we see that growth. I'm including a slide for the medical people in the audience, a graph, so you can see that. But the thing is, the question becomes, not only is there so much of it, and there is so much, and there was an article that was published in 2010 that said that there were 75 clinical trials and 11 systemic reviews published a day. A day. And so there's so much to know. But I think that keeping up with that knowledge is one question. The other question is, how do we use this knowledge? How do we use the knowledge that we already have? Because if you think about it, when you have all that information out there, we don't just sort of like passively receive it. We're choosing which information is valid. And when I think about some of the mistakes that I make or some of my residents make, is they'll force it. Like, I'm listening. This guy has all these complaints, but I'm going to listen. I'm going to listen for the chest pain story, so I'm choosing the chest pain pieces. So they're asking questions with the end in mind. And when you do that, you sort of cut off all the opportunities and all the other information that might be just as relevant, if not more so, but you totally dismissed it. And so we privilege certain information, we discount others, and those decisions about what is valid and what is relevant information, again, is decisions that we're making even before we think we're actually making the important decisions. So we have to be sensitive to our decision-making minds at work. That's paying attention to our process. When we think about the misdiagnosis rate of around 15%, it's usually due to cognitive traps, and it's not due to lapses in knowledge. Not only is medical knowledge never ending, but it's constantly shifting. There are reports that standard medical guidelines, are changed around 20% a year. So that puzzle, that base is constantly moving. And we can't forget that even if we have the best knowledge and we're confident of the evidence, we can't forget this fact, which is the fact that even decisions that are grounded on the best evidence can be charmed by our mind's attraction to story actually over statistics. The confidence that we have in our beliefs is not always a judgment on the quality of the evidence, but a judgment on the coherence of the story our minds have managed to construct. So this is a quote from an article by Jerome Kesserer, who was the editor-in-chief of the New England Journal. And this is from 1979, and it's about uncertainty. This is back in 1989. He says, absolute certainty in diagnosis is unattainable, no matter how much information we gather, how many observations we make, or how many tests we perform. The truth of the matter is that our tendency as physicians or clinicians is that when we're faced with uncertainty, our impulse is to reach for more data. When perhaps we need to become more honest with our patients about the boundaries of knowledge. And we order more tests. That was the premise, the driving force for Dr. Kesserer to write this article. But as he stated, more tests does not necessarily lead to more certainty. And I see this all the time in our work, that you can order so many tests, but you never get to that point where you don't have to interpret. That judgment does not enter into that you have to enter that subjective space. So we're trying to defer responsibility, but eventually we have to make that leap. And sometimes more facts does not make that leap any easier. A couple of months ago, in another article, actually in the New England Journal, by Dr. Simkin, said that in order to thrive in the future, we must acknowledge and accept uncertainty for our physicians, for our patients, and for our healthcare system as a whole. And they made this wonderful statement. They said, our obsession with finding the right answer at the risk of oversimplifying the richly iterative and evolutionary nature of clinical decision-making is the very antithesis of humanistic, individualized, patient-centered care. Luther and Crandall, in an earlier article, said that physicians who are less comfortable with uncertainty are actually less likely to discuss this uncertainty with their patients and are less likely to engage in shared decision-making. And we also have to remember one thing, is that physicians are actually overconfident in our diagnoses and our accuracy. And it's been shown in studies there's a mismatch between our certainty about our diagnosis, regardless of the case difficulty, and our accuracy. And this mismatch might prevent us from re-examining typical cases where the diagnosis might in fact be incorrect. So to reset expectations, physicians must cultivate greater personal comfort with uncertainty. And to go back to 1989 and Dr. Kresser's quote, he said, "We must take a hard look at the ways we teach students and house staff to approach uncertainty." And that was 1989. So I think part of our uncertainty problem starts with the certainty problem in medical school. By that, I mean that in medical school, students are judged by what they know. I mean, that makes sense. They learn facts and they answer questions designed to test those facts. And in that context, to not know is to be wrong. And if you don't know enough, you fail. And then if you fail, that could be a source of shame. To not know, actually, we risk looking foolish. However, not knowing is essential for creativity and for creative thinking and for artistic thinking. The writer Donald Barthelme wrote an essay called Not Knowing, and he said that's essential for the artist. Not knowing is essential for the artist. It's crucial, and in fact, the more serious the artist, the more problems that he or she takes into account. And that if we favor easy problems, we're actually evading our responsibilities. And the work of an artist is interpreted in part by what questions he or she is asking. I mean, writing and art making is a process. And that's not immune, that focus, that intimate detail is not necessarily immune to what we do in medicine. But process usually is on a systems level. How can we move patients to the emergency department quicker? How can we reduce catheter-related infections, and so on? However, we spend less time focusing on process, on the individual decisions that we're making at the bedside. So, one area that I'm very interested in is the role of story. Especially years ago, after my first book came out, I was visiting someplace, and I was out for dinner, and this very well-meaning clinician said to me, he goes, "I don't get it." And I'm like, "What?" He goes, "You're an ER doc, and you're interested in story." And I'm like, "Yeah." And he says, "You guys have no time for stories." And I understand what he was saying, but I was looking at it differently. I was looking at the fact that we have so little time to get patient stories is the very reason why we need to get our stories right. Just because we don't have the time, it doesn't absolve us of that responsibility. And I think we have to think about what we think of, change our perspective of what we think of as a story. I mean, I do this all the time. Send a resident, send a student into a room and say, "Listen, get the patient's story." As if that story is just like this total precious thing, and all the resident has to do is go in and get it. But the truth of the matter is that these patients are not, most of my patients have not been to medical school. So they don't know what's relevant or irrelevant information. Sometimes they give me nothing, sometimes they give me everything, right? And it's like, here. And they're more like narratives under construction. And I actually look at them oftentimes as first drafts. So there was so often that I'll go in and I'll get different information than, let's say, a student or a resident. And I'm like, God, how do you do that? And I'd like to think that it's due to the fact that I've been at this for a lifetime, and I'm old as dirt. But the truth of the matter is that the patient probably came in and went to triage, and they asked a series of questions. For example, do you have chest pain? They go, "No, I don't have chest pain." And then the relative will go, "Mom, yesterday, weren't you complaining of a little chest pressure?" Oh yeah, maybe it was. Then they get back into a room and they talk to, maybe another nurse or a resident or whatever, or somebody else, and they'll ask questions again. They go, "Well, you're short of breath. Are you tired?" "No, I've been feeling okay, but I had some chest pain, but otherwise I felt fine." "Mom, remember you slept a little bit more yesterday than you usually do?" "Oh, yeah, I did." So when I go in there, I get the chest pain, I get the fatigue, I get everything. So I get the fourth or fifth draft. So maybe I'm asking different types of questions. I hope so. I hope my years of doing this counts for something. But also I'm getting a third or fourth draft of the patient's story. But it's really important to sort of write stories, to actually get there, to get on a ground level. Because it gives you a different understanding of story than actually sort of looking at stories as these perfect things that you then have to sort of just understand and interpret and take almost like a reductive understanding towards story. And there are a couple of things that I think you get from writing stories. By writing stories, it really forces you into hand-to-hand combat with a sentence. You know, you get a chance to see what how language operates. You play with language and meaning, and you become sensitive to how multiple narratives work and will play. By writing stories, you understand how hard it is to actually tell stories, the fear and the vulnerability involved, and also sharing profound experiences with strangers. By writing stories, we relate differently to language. Not only what is said, but what is unsaid, what you trip on, where are the gaps, the critical silences and the evasions that might contain the very thing that you need to hear, but the patient isn't saying for one reason or another. I love this quote from the actor and the playwright Anna Deavere Smith, who said, "We can learn a lot about a person at the very moment that language fails them." So we also have to recognize how stories work on us. Not just how we work on stories, but how stories work on us. Our brain craves stories. We'll weave random, incomplete information and data into a story, whether we realize it or not. And the dangerous part is that it cares little for information that it doesn't have, and it makes it susceptible to creating a recognizable story or shaping a more convenient story, which is very different from the one the patient might be trying to tell us. We make this, and this is important in the clinical context, because we make decisions based on these stories, and that the best medicine doesn't always work on the wrong story. And what I've discovered oftentimes is that when we have suboptimal outcomes in medicine, oftentimes it's not the product of bad physicians or physicians who didn't know, but actually very smart physicians, skilled physicians, who just got the story wrong. So this was just an example. This was a classic study in the social psychology literature from Fritz Heider and Marianne Simmel. And they showed this video, and they asked their subjects what they saw. So I'll play that. It's not showing. I'm sorry. So anyway, I'm sorry. What this shows is there's a bunch of geometric shapes moving around the screen, and it created this drama. And they were asked the students, "What did you see?" And they came up with sort of courtship rituals. They came up with drama. They came up with bullying, and only one person in their study actually described what they saw, which was geometric images moving across the screen. So this is how our mind will create inconvenient convenient narratives, even out of sort of geometric shapes. So this idea of doctors as makers, I borrow from the maker movement, which is sort of this movement of sort of independent tinkerers and designers and inventors who in the past have sort of worked in isolation and through social networks and communities have developed the resources to sort of make the connections, to find the knowledge that's out there that might have been unavailable to them in the past, and to leverage on community knowledge and skills to create, to turn from passive users to sort of active creators. And this idea sort of came from actually conversations that I've had with several people at Brown, one of whom is Ian Gonsher, who is a designer, an artist, and in the engineering department at Brown. And he started something called the Creative Scholars Project at Brown, where it's sort of a loose band of people who have meet on a fairly regular basis, people from Brown, people from RISD. And it was in this context that I started thinking about what we do in medicine and finding parallels between that and sort of the maker movement. And what I realized is there's so much knowledge out there, and that's actually what's in our devices. It actually truly boggles the mind. And that medical students and residents really have no problem accessing that information. They can access this information much better than I can. But that works when there's a missing puzzle piece, and it might not work nearly as well when you're confronted with a Twombly. When I talk about the value of not knowing, I have to make one thing perfectly clear, and that was mentioned to me when I was submitting this article to Academic Medicine. And that's when the editors say, Jay, you have to put something in there that you have to know things. I don't want medical students, people writing me saying, Baruch says it's okay if I don't know. No, you have to know things. You have to have a fundamental basis of knowledge. The point is that it's just not enough. It's not knowing is not necessarily a lazy shrug to lower our intellectual bar, but it's actually a clarion call for a different type of rigor in medicine, one that welcomes an openness of mind, creative thinking, a different way of framing problems and looking at constraints differently. And I think it also changes the responsibility of healthcare educators from purveyors of facts and guides to help students interpret and make to people who are actually going to help them make meaning of those facts and how to apply those facts in unstable environments. Again, I borrow from Donald Barthelme. I think that applies to medicine. I think the problems that we choose to dive into speaks to the type of artists and the type of physicians that we are. So, how do we do this? So I think that the challenge of facing medicine demands new partnerships. I think that we need to reconceptualize the healthcare team to include artists, designers, and humanities scholars, because the skills and the point of view that they bring to the conversation is, I think, desperately needed. Not necessarily on humanistic grounds, but on instrumental grounds. At Albert Medical School, we have programs that provide opportunities for students to work with various different arts-based experiences. We have developed programs with the Rhode Island School of Design, with RISD and the RISD Museum. We've had a relationship with the Trinity Rep MFA program, Artists and Scientists as Partners, which is dance, and numerous others, artists and artists/physicians, clinicians of all stripes. And what we do here is create spaces where students can play with uncertainty and not knowing, develop comfort with novel experiences, and to think openly and make connections between different types of ideas. And also, I think, more importantly, actually, to discover and become more comfortable with their own vulnerabilities. These take place in many different areas, from lecture halls to horse stables, design studios to museums. We want to also bring students into a fresh relationship with their thinking process, including trying to find connections in which artistic practices can function at the bedside. So rather than just go into sort of detail with a lot of things that we've done, I'm going to sort of choose a few selected didactic venues and just share with you a couple of things that I've learned from those experiences. So it's really nice to say, we need to think differently, and we need to have these collaborations. But it takes a lot of work to have these collaborations. It's a lot of meetings. It's a lot of being open to what these other arts-based people, whether they're designers, whether they're artists, whether they're writers, whether they're dancers, whether they're musicians, whether they're illustrators, not only how they can sort of help you, but how you can help them with their work. And the most important thing that I've learned in cultivating these partnerships is that I go into these conversations with my white coat in the closet. I go in there with my writer's hat on and not my doctor's hat on. I'm not going in there saying, what are you going to do for me? But I go in there with the curiosity in which they face their own, which they approach their own work. And again, we focus a lot of the conversations are oftentimes on process, sharing ideas, rather than saying, I want to do X, but actually thinking about what we each are doing and how our aims can be mutually beneficial. My work started in a more formal fashion with a course that I co-created and co-taught with a colleague who was at that time was at RISD, Kelly Auerbach. She was an MFA in creative writing at Brown. She was a writer, novelist, and a screenwriter. And we basically took we took medical students and actually 2 or 3 undergraduate students who forced their way into the course, and RISD students. So we had them working in teams, and the curriculum was built upon topics that were of interest to both parties. And the goal of that course, and why I think that course was successful and we got such a great response, is that Kelly and I worked together on this syllabus for probably around 6 months. And though we bandied back and forth about how we were going to approach it, we shared a common vision. And that vision was that we were going to take risks, and there was going to be an ethos of experimentation. And soon as we knew that we both were in there with the same space, we were fine. And as a result of that course, I came out with a different understanding on feedback. You know, how artists and the art students, the RISD students, were very comfortable giving and receiving feedback. And the medical students, not so much, at least not in the first couple of weeks. But then gradually they were able to become better at sort of sharing their opinions, justifying their opinions, making suggestions perhaps on how to improve, and being comfortable being wrong. You know, and realize that other people are going to have different opinions. And the way the 2 groups sort of looked and observed and interpreted the world, we wanted them to sort of bounce that off each other and see. And so what happened was some of the medical students ended up continuing with this work. Some of the art students used some of the medical themes to inform their work. So it was beneficial from both sides. We also have an integrated clinical arts, which is a half-day mandatory session at our medical school. And we love the fact that we actually have that half-day. And again, this was started by Kevin Louis, who is now an internal medicine resident, but a medical student at that time. And it was his medical humanities, part of his medical humanities and bioethics scholar concentration project with me. And again, students spend a half day doing something, taking some kind of creative workshop, and that workshop can include writing, to medical illustration, to dance, to theater, to going to horse stables, to learn about dealing with nuance and ambiguity and being adaptable and reading others. It's around 8 or 9 different workshops that's going up as our classes grow. And why this has been so vitally important, even though it's just a half day, is the fact that it does make it clear that we value creativity. There's no ultimate aim involved. We let students make the connections, and students will make the connections when we do our evals after that. It promotes community amongst the artists and the students. Many artists in local artists who will participate in this will end up doing further projects. Two of them had actually ended up creating electives based on that started with their experience with the medical students. And it also just allowed students to remain tethered to their native talents. They don't have to lose their incredibly important and creative work that they came into medical school with. And it really has been a jumping off point, and it gives students permission to pursue those things, those artistic impressions that they think is so critical to them. Healthier by Design, which is, again, a student-led project, which is us with Alfred Medical School and the Rowland School of Design students. It was started by a medical student, again, Ravi Sarpartwari, who's now in a first-year emergency medicine residency with us, I'm proud to say. And Ravi was an architect before he went to medical school, and he and 3 RISD students started this program, and we just finished our 4th year with that. And the course itself focuses a little, it's based on sort of design thinking, though the designers in the course sort of ask us to pause when we think about design thinking because they feel it's sort of being co-opted and think this is design thinking. However, what has been really, really important that we're getting out of this course is that this year, because it's a 6-month course, students were sort of latching onto projects that were already being done, either in the community, by startups, by researchers that had design component to it. And this year, students were actually sent off into 4 different locations, and they had to do the observation, they had to sort of search for problems, try to come up, try to find out how the users are using the space, to come up with prototypes, and put their minds at work and sort of iterate and get feedback and come up with final projects. And we have designers from RISD, we have engineers involved now from the university, we have startup incubators who have lent their support now to this program. And I will say this, that if you really want to see students have a better or deeper appreciation of what empathy means, it's through design. By having them really sort of empathize with the users, actually fill a space, observe a space, and watch people trying to understand, work through it, and understand that experience in a palpable way is actually through design. And then lastly, our work that I'm really proud of with the Rhode Island School of Design, the RISD Museum. And this was created by museum educators and us. We didn't come in there with an agenda. It ended up evolving into a focus on critical thinking and the role of creative thinking in medical decision making. And what I learned from the museum educators are this, and I think what the students have learned as well. How to challenge our assumptions and how we test our assumptions. How the museum, with all its beauty and quietness and just this peaceful island, is just a fantastic space to get students to learn how to think in unstable environments. The museum educators themselves, how they teach, is something that we all, I think, can learn. I learned a lot from. And most importantly, is the willingness to tolerate silence. To actually just sit there and let the students sort of look, and they'll ask a question, and they'll just comfortable. They'll wait all day. Luckily, it's not all day, but they'll wait, and they'll ask open questions. And I think students also see how these groups of educators are able to engage a number of sort of medical students or residents who are somewhat skeptical about this process, and yet they just win them over. And I think that's how they do that, how they engage with their audience, is something that we can take into our relationship with our patients. I think students also see modeled behaviors in which people from different backgrounds, physicians, clinicians, nurses, social workers, and the museum educators can work together and actually have difficult conversations. And there's this quote from an arts educator, Julia Marshall, that just shows that actually the work of of artists and arts education is not much different from medical education. And she said that there are 2 kinds of learning that are developed through the viewing and the making of art: declarative knowledge, knowledge of content, and procedural knowledge, which is knowledge of how to apply that content. Which I think essentially is what we do as in our work in medical education. So, who would not love to have this as your aim as a medical educator? We are committed to fostering creative and critical thinkers who innovate with ease, who are not rattled by uncertainty, who move agilely from one form of output to another, and who can communicate in multiple ways with acuity and clarity. This is sort of my goal, and what I'm trying to do with my work. And yet, this was not written by a physician. This is written by Roseanne Summerson, who is now the president of the Rhode Island School of Design, in the book, The Art of Critical Making, which is a fascinating book on the curriculum at the Rhode Island School of Design, a internationally known arts education school. So, does the metaphor of the doctor as maker stretch too far? Let's face it, it's easy for me to say that we must accept failure and risk-taking. But I'm also mindful of the fact that, some of the most powerful people and the best dressed people in any hospital are those in risk management, and they have us manage risk. I'm also well aware that medicine demands replicability and quality and consistency. And how does that call for creativity align with these expectations? Because we are evaluated and judged and rewarded according to our outcomes, and not necessarily to the rigor and ingenuity of our processes. However, uncertainty and doubt pervades medicine. And if we take one lesson away from our current healthcare crisis, the levels of complexity facing future physicians and our patients will only multiply. They say that every creative journey begins with a problem, and it's defined by constraints and obstacles. And I think all of us are aware of the many boxes and the challenges in our practice. Artists looks at constraints differently. Obstacles and limitations force us to shake off the familiar and to look closely, to think differently, and to make new connections. To be creative is work, but anyone can be creative, especially doctors. Thank you very much.
Thank you so much. You've given us lots to think about. Yes.
So I'm only as good as my collaborators. In fact, my collaborators make me better than I actually would have been normally. And this is just a short list of all the people that make this work important and relevant and real. And from my chair of emergency medicine to emergency medicine to the medical school to the various leaders and groups at Brown, to local artists and my students and everyone else. So I really want to make certain that they get their due, because it's really their work, and I'm sort of just a connector.
Thank you, and that's quite an impressive list of partners. Also, lots of meetings.
A lot of meetings, but they're also,
But good combined work. Yeah, and this kind of work that's going on at Brown is also going on in a number of other institutions, including at UVA. But now is the opportunity for those of you who are here from many different disciplines and areas of the university for you to have your say, ask questions, offer some comments. We have a mic on that side as well, and we'll bring a mic to you. If you have a comment or question, please also identify yourself.
Hi, Jenny. Matt Trowbridge. We know each other, which is wonderful.
You owe me money, right?
Probably. We'll talk about that later. Yeah, exactly. So as you know, I'm also very interested in the same domain. I love how you're coming at it in a slightly different way with the focus on explicitly engaging with kind of creative disciplines. As you know, we're trying to build our own design thinking program for medical students here. What Marcia said is really important, is that idea of all of these types of experiences. They take a huge amount of work and a lot of time. And so to make them sustainable, they need buy-in at a full institutional scale. How have you, all the metrics you talked about and the types of ideas that you're talking about in terms of what a future physician should be able to do from these, they make total sense, at least I think they do. How have you, how has that conversation evolved at a Brown level to be able to say how Jay is spending his time, for example, if you understand where I'm going?
Yeah, so that is a sore spot. No, it takes so this type of work. I mean, what I love about creating curriculum and programs like this, and what I sometimes find very anxiety-provoking about creating programs and curriculum like this, is the creative nature of it, right? I mean, that's what's fantastic. It's like you're trying to sort of do something that is new. And that speaks to needs that perhaps haven't been spoken to before. And so, to be on the first level, I have buy-in, because I have an emergency medicine chair who feels that this is important. I think to have chairmen who validate this type of work is, because you need someone who's above you, who's above your who could say, no, I think he's not crazy, I think this is important. And so one is from a logistical perspective, puts bread on the table and that kind of thing, and I have an emergency medicine chairman who thinks is important. I also work with an emergency medicine faculty that thinks this is important too, when I've cultivated relationships within that. So much of the successful programs at the medical school are grounded in student ambassadors. You know, because you can talk all you want about, this is important, this is what I learned from 20 years ago, 20 years, and this is it, and I don't want you to make the same mistakes that I made, and blah, blah, blah. But the truth of the matter is, you need people who are students who are there saying, this is important. You know, this is important. And so when we first started doing this work, we had like people like Kevin Louis and people like Robbie were sort of student ambassadors. And they also had that startup spirit for academics and curricula. Because if you wait for big people, like decisions to be made up here, sometimes they don't happen because there are too many political agendas, and you have to sort of take almost like this guerrilla approach to education. So a lot of what we ended up creating was actually outside the curriculum, and we showed people what we mean when we were teaching this. I actually had a lot of buy-in from people outside the medical school that on campus, and generated those relationships that then helped move things into the medical school. I think now, Matt, we're in a better place. I think even 5 years ago, people were still trying to make sense of this, and now I think we're in a little bit of a better place. Some of that resistance that we had before, we're not getting nearly as much, but we're also battling curriculum time. You know, there's a limit. There's always everyone's wrestling. If there's going to be a new reality TV show, it should be wrestling for curriculum time.
Thank you.
Hi, I'm Lois Shepard from the Center for Biomedical Ethics and Humanities. And I've been hearing a lot more about play lately, the concept of play, and I'm wondering, I mean, I totally appreciate all of this. It's great, but it still seems there seems to be an element of working for creativity and working towards creativity. And I'm just wondering how much in your program you're thinking about play. It's hard to have measurables with play, you know, and then justify your programs and your activities. And I'm just wondering if you've had some thoughts about, all within the creative realm and with the same goals, but if you've had some thoughts about work and play, and when you know you're doing work and when you know you're doing play, or any thoughts on that?
Yeah, that's a great point. And a lot of what we do, like, we might not necessarily explicitly say, like, our role is the role of this is to make you more creative. It's not, it's to sort of make you a better writer, to have you engage in dance. I think we're sort of intellectualizing this a little bit because we have to from a curricular perspective. We try not to steer the ship too stiffly, so there is that element of sort of play. But if you think about it, that line between play and work is so thin, if there is one, because sometimes there's great work, some creative ideas come from quote unquote play, and the ability to sort of take off that white coat and to sort of engage in behaviors and activities as yourself, which is what we end up doing. I'm a different doctor than every one of our people in my faculty. We all practice differently. We have the same wealth of knowledge. I think they're better at ultrasound than I am. But a lot of it is because of our own personalities, like it's what we bring to the table. So I feel there is a place for play, largely because so many great ideas, new ideas come from that type of freedom and dropping the walls. How do you measure that? We talk about the measurement piece, all the time. It's like, and so, if you have a potentially valuable activity, but you can't measure it, does that necessarily mean that you shouldn't do that activity? Does the measurement piece limit those things that potentially have valuable importance? And do you end up doing lesser activities or create less inventive curriculum because it's easier to measure? So that's a question, a dialogue Marcia and I have had, and many of us have had on a sort of national level, as we create more and more curriculum, because at some point it is kind of important to capture this experience. Especially if we want to find our spaces in medical absolution, it doesn't absolve us from the responsibility of trying to somehow capture this.
Hi, thanks so much for your talk. I'm Gloria Ravel. I'm a new faculty member in the Department of Pediatrics, so your talk really spoke to me as I continually dealing with all the ambiguity and uncertainty that I find. My question is, I think, how do we negotiate that with the patients? Because I think there are times where I've accepted my uncertainty, but I don't know how to negotiate that with a parent or family member or patient who I feel like, maybe this is my perception, but I feel many patients really want that certainty.
Yeah.
And how to have that conversation.
I had to tell you, I'm really honest with my patients. And they'll sit there and go, what do I have? And I go, do you want me to give you a diagnosis? I go, I'll give you a diagnosis, but it's not, but I'm making up. I'm very honest. I go, this is what we're going to try to do. I'm going to try to find the things the worrisome things that we're concerned about, try to take those off the table. And I say there are two things I never say in medicine. And I probably say this how many times during a shift? I go, I never say never, and I never say always. Because a body just doesn't, it just doesn't read the book. And you'd be surprised how people sort of welcome that. And then it's not just the fact that I can't give you an answer, but this is going to be a process, and this is the answer. This is what we can do here. This is what you might need to do afterwards when you leave here, and this is perhaps how I can help set that up, and what I can do. So you don't want to feel like you're just shucking them off. You want to feel like, listen, I'm going to be honest with you, but I also want to show you that I really care about what happens to you, and I'm engaged with you. This might be a little bit different when you have a little kid and you go, it's uncertainty, I can't tell you. And when you're dealing with adults. And I don't want to talk about the challenge that you're dealing with parents, right? Because that's sometimes they want that certainty. But I have to tell you, I am just really honest with them. And make sure the tone is that of, honesty, transparency, and this is what I am, this is what I can do for you. And then if you have any questions, let's talk about that.
So in an encounter like that, if you back up and the doctor is uncomfortable with the uncertainty, then it probably is, you're not going to have that conversation.
Well, how many times, even the medical students who are in the room, you sit there and we all started, you ask about, sexual history. Do you have, and you're sort of eyes rolled, you sort of stumble a little bit, and then all of a sudden you're asking all kinds of crazy questions. You become familiar and very comfortable in that terrain. And just a conversation that as soon as, the more and more that you have with them, I just found it was easier. It's easier than sort of the energy of trying to make something up, or try to give them false certainty. I just felt weird about that. It was more internal than intellectual. A lot of problems that I face, especially bioethical problems, or I feel in the gut before I feel in the brain. I recognize I'm having it, and those are those situations that just makes me sort of uncomfortable with myself.
Time for one more question? Okay.
As you have great experience in emergency medicine, can you give an example when your creativity helped you a lot?
So there's a case that I've used in a previous talk. So years ago, I had this patient who was brought in by three or four EMS, two EMS people, and the police, right? And that's never a good sign when you have EMS and police. And there was a question of whether he fell, he was at home. He was a decorated war veteran, young guy, built but really strong, and refused to wear his cervical collar, refused to lie down. He came in walking He denied having fallen or anything. He had a ruler or something up here in his head. And he was acting out. He was, and trauma center, like we have a certain protocol for patients who are acting out. People act out for a lot of different reasons, whether it's substance abuse, whether it's alcohol, whatever. And then there was also the possibility that this was something that was medically related, like a head trauma. And we knew he had a history of PTSD. That's what they were telling us. And so he's in this room, and he's surrounded by 8 huge security guards. And he refuses to be, there's the nurses sitting there with the restraints and looking at me. And this is, I was relatively new at my present job. And for some reason it didn't feel the same way. Like it didn't look like he was agitated in a way that related to some kind of physical ailment. It looks more sort of psychic. It just didn't feel the same way. And they wanted to restrain, they wanted me to get control of the situation. And they had the medication ready, restraints ready. And I left, his family came, and I asked to speak with them outside the room. And I'm talking with them. And they were like, where you going? I'm like, where you going? Like, and I'm like getting 0 marks. I'm getting no points with my staff at this point in time. But I'm like a band, I'm like the captain of the ship, and I'm like, okay, you guys deal with that, and I'm jumping off, going to the lifeboat. But that wasn't the case. I went into the hallway, and I was saying, okay, so this is where we're at right now. And I wanted to know about his PTSD, and a little bit more about his behavior, because the family was upset, because they say he never acts this way. This is totally uncharacteristic of him. And what I learned, again, when you're stuck, sometimes you move backward, right? How did I get here? How did we get here? Like, what do you know? And what I ended up learning with that is PTSD had nothing to do with his military history, which is what everyone thought, and it had roots to back when he was a child, when he was raped. And then you look at it, I poke my head into the room, and you see this guy basically sweating, agitated, cursing everybody out, and he's surrounded by 8 huge guys. And so again, we were in reflex mode. This is how we handle this type of case, but not necessarily. But the question really was to step back and saying, what is different about this, and how do we deal with this particular person in this particular situation? And so the response was not medications, the response was not restraints, the response was kicking the security guards out of the room, which took a leap of faith on my part, because I did not know how he was going to behave. And it went on from there. But that's, I think, one situation that stood out where understanding the story and my sense of writerly skills, trying to understand the situation and not being able to make sense of it, and how to go about understanding how we got here, led to a different understanding and a different response to the case at hand.
Thank you. And I think we close this session with an example of how story teaches, and what a master storyteller our speaker is today. So thank you.
Thank you all.
Jay Brewer.